Good afternoon, and thank you for joining us for Tampa General Hospital's Ask an Expert, a live Q&A series. I'm your host and moderator, Danielle Kachi. Thanks again for joining us, and we are also joined by Dr. Shone Almeida. He's an assistant professor at the USF Health Morsani College of Medicine and director of cardiac CT and the Cardiometabolic Disease Prevention Program at the Heart and Vascular Institute at TGH. Thank you so much for being here today, Dr. Almeida.
Thank you for having me. It's a pleasure to be here.
All right. Well, we all know that February is American Heart Month. So, of course, we're talking heart health today, and specifically cardiometabolic disease with one of our leading cardiologists here at TGH and USF Health. Before we get started, though, we do want to go through a couple of housekeeping notes. First, if you have any questions during our live session, be sure to place those in the comments section. We've actually already had a ton of interest in this topic with some pre-submitted questions. So we'll try to get to as many of those as we can, but we may not be able to get to every single one just because of time constraints. And a reminder that yes, Dr. Almeida is a medical expert, but make sure that you're always consulting your primary care provider for individualized medical advice. All right, now that we've got all of that out of the way, let's get to it, Dr. Almeida, with our first question. It comes to us from Miriam, who's asking a great one to get us started. What is cardiometabolic disease exactly?
So that is a great question. Cardiometabolic disease is trying to reflect the concept that we cannot take heart disease in isolation. And in fact, heart disease is a complex interplay between lifestyle choices and other comorbidities such as diabetes, high blood pressure, high cholesterol, that all come together to cumulatively determine our risk for future heart disease and heart attacks. So cardiometabolic disease really tries to attack heart disease as a whole, not only just addressing plaque that may have formed, but addressing all of the other components that can contribute to heart disease formation and plaque formation.
Great. All right. Our next question comes from Sheena. She's asking, what patient population do you select for coronary artery calcium or CAC scoring, or do you use CT coronary angiograms? And would you use either in asymptomatic or low-risk patients?
Sheena, that's a great question. So let's unpack that a little bit. Taking a step back, coronary CT scan really is just any type of CT scan you may have had in the past, but this one takes thin slices through the heart and specifically helps us visualize the heart arteries. So coronary artery calcium scan is a non-contrast study. We don't give you any medications through the IV and essentially allows us to look at hard calcified plaque in the heart arteries as a marker of what heart disease may be present and helps us predict what your future risk is for a heart attack. In contrast, a coronary CT angiography involves giving IV contrast or X-ray dye through your veins to help light up the blood arteries, the heart arteries. And now it helps us visualize in more detail not only hard calcified plaque, but also soft plaque that may be present, and helps us assess if there's any heart vessel narrowing. In current guidelines, a coronary artery calcium score is appropriate for patients without symptoms to help us better understand cardiovascular disease risk in combination with your risk factors, comorbidities, etc. A coronary CT angiography is used for symptomatic patients such as chest pain, shortness of breath, again, helping us to better visualize the heart arteries to see if there's any narrowing or blockage. But it's an interesting question that you're asking because, in fact, one of the things we've started doing in our cardiometabolic program is doing coronary CT angiography as a screening tool, so in asymptomatics, to help find plaque at its earliest stage. We don't want to wait till we find disease at 50, 60% narrowing when someone may be having symptoms, but instead, we want to find it at its very early stage when there's soft plaque that may have taken hold and help to address some of the risk factors that may have led to that.
Very helpful. Thank you for breaking that down for us. Our next question is from Nancy. She says, or she's asking, how does she get her calcium score lower? It's 370 now, and it was 250 last year.
Nancy, that's a great question. So, coronary artery calcium, there's a lot of misconceptions around it. First of all, the absolute number has to be taken into account with age and gender. For example, if you're a 45-year-old woman with a calcium score of 5, let's say, that automatically puts you in the 90th plus percentile. Whereas if I take that same value of 5 in a 65 or 70-year-old, it would put them in a much lower percentile. So you have to factor in age and gender. But to your question, how do you get your calcium score lower? In fact, that will never happen. And one of the reasons for that is one, coronary calcium will continue to develop and progress, especially if left unchecked. And two, a lot of the therapies we use, specifically the statin class of medications or PCSK9 inhibitors, these are another type of lipid lowering therapies. One of the main things that they do is they help to change our plaque phenotype. So, in other words, they take some of that soft, non calcified, higher risk plaque and they help convert them into more stable, hard calcified types of plaque. And in doing so, they will in fact raise your coronary calcium score. So if you're on therapy, that calcium score will have increased, and that's expected. But if these are increasing without any therapies in place, and in fact, if they're increasing, for example, over a 4 to 5 year period, if we're seeing a significant jump, this may clue you or your provider into a rapid progression of disease and perhaps help you decide how to take more aggressive control of your risk factors.
Good to know. Thanks for that one. And we do want to get to a couple of shout outs. We have comments coming in here. Emily says, big thanks to Dr. Almeida for all the amazing care and expertise. You're a great doc who always listens and explains things clearly, as you're doing right now. So thanks, Dr. Almeida. We'll keep it going with our next question from Helene. She's asking, does taking a statin stop additional plaque production?
Yes. So this is a really important concept. So statins as a class are one of the first line tools we have in curbing heart disease progression. So statins we all think about as being cholesterol lowering therapies, and that they are, right? The main target that we rely on is lowering of the LDL. And if you lower the LDL, what I like to tell patients is that it's like taking away food for the plaque forming process. Now, plaque formation is a complex interplay that goes well beyond just cholesterol. But if you lower the LDL, you can lower plaque progression and prevent new plaque from forming. So statins as a class become really important to not only prevent new plaque, but then all those other benefits that we like to derive from them. As I mentioned before, they help to change the plaque phenotype. So they convert plaque from soft to a more hard, stable form of plaque. They can also help to thicken these fibrous caps that overlay plaque, reducing the risk of rupture. And they have local anti-inflammatory benefits on the coronary level, and we know that inflammation is a key driver for plaque formation. So for many reasons well beyond the LDL, statins are an important tool against heart disease.
Great. Our next question comes from Barbara. Tough one here. She says one artery is 60% blocked. She wants to know if she's a heart attack waiting to happen.
Barbara, thank you for the question. It's hard to decide or hard to predict which blockage, which lesion will rupture, leading to a heart attack. Remember that heart attacks form when plaques rupture, spilling that lipid content into the blood vessel, triggering an inflammatory and clotting cascade that leads to cessation of blood flow in that vessel. That's an acute heart attack. So a 60% blockage, it's hard to predict if that particular lesion is going to be the one that ruptures. Now, a lesion or a plaque may narrow over time, causing stable angina, stable chest pain, but that may be a slow process, especially if you are appropriate therapies. But it's hard to predict if that particular lesion is the one that's going to cause your future event. Now, the fact that you have that certainly means there are risk factors that are driving it, whether it's family history, inflammation, high cholesterol, diabetes, kidney disease, etc. So it's important that you discuss with your doctor all the tools that are possible now to help curb that risk.
Gotcha. And speaking of discussing with your doctor, we do have a comment coming in through Dr. McMillian. who's asking, what is the best age to have a screening test?
Thank you. Thank you for that. So it depends what kind of screening test we're talking about. If we stick with guidelines, a coronary calcium score is indicated at age 40 for men and 45 for women. And the reason is because we recognize estrogen is protective earlier in life in women, and thus we may not see that coronary calcification until a little bit later. Now, certainly, if you have more risk factors at a younger age, for example, there's been studies done by Mike Blaha and colleagues that have shown if you have the more risk factors you have, even in your mid to late 30s, you might certainly develop coronary calcification sooner, and that would be a reason to screen much earlier in life. As I mentioned early in the program, that we use coronary CTA angiography for early plaque detection. And in those settings, I might consider using a CTA for screening if you have sufficient risk factors, such as family history, smoking, diabetes, high cholesterol, chronic inflammatory conditions, to screen much earlier, mid to late 30s, and certainly into 40s for men and women.
To know. Thanks for answering that one. We have another question from Sheena. She's asking, do you check ApoB and lipoprotein routinely, and does insurance cover it?
Sheena, I'll take the second part of your question first. So insurance coverage is quite variable for some of these blood markers. So lipoprotein B, and lipoprotein A are additional markers, blood tests that physicians can use to help better risk stratify your future cardiovascular disease risk, right? So this would be in conjunction with, say, your LDL, your lipid profile that your doctor might normally order. But coverage does vary quite a bit, so it's hard to answer it without knowing your particular circumstances. But in our cardiometabolic clinic, yes, indeed, we do check apolipoprotein B in everybody. It can be a better tool to monitor treatment efficacy. And lipoprotein A is certainly something that everyone should get at least once in their life. In fact, it doesn't change a whole lot throughout your life, so you really don't need to have it repeated. And lipoprotein A, think of it as LDL particle, but worse. So it's more atherogenic, more likely form plaque, and more thrombogenic, more likely form clot. And so if your lipoprotein is elevated, it does suggest a even heightened cardiovascular risk profile. And while we don't have direct targets for it now, they're coming in the next 1, 2, 3, or 3 years, pending FDA approvals. It does mean that you should be closely monitored and followed.
Good to know. We'll get to our next question from Roseanne. She says, is being vegan and exercising vigorously daily enough to lower an LDL of 180? She's of Native American and Hispanic ancestry and is concerned that her medication could elevate her blood glucose.
Roseanne, lots to unpack there. So I think you've brought up a couple points. There's no doubt about it that lifestyle, what you eat, how active you are, does influence your cardiovascular risk. Certainly alters your lipid profile as well. Being a vegan and avoiding animal products can certainly keep your LDL low. But keep in mind, LDL, when it's checked, is a cumulative value that accounts for not only cholesterol that you intake from food, but also the liver's production of cholesterol. A lot of our therapies, in fact, the majority of them, target the liver's production of cholesterol to lower your total LDL. So the fact that yours is 180, being a vegan, might suggest that there are maybe other factors at play that's leading to that cholesterol. And the way I like to think about it is that you're essentially bathing your heart arteries, and all of your vasculature for that matter, in that high degree of LDL for quite a long period of time, which may increase your propensity for developing heart disease or plaque. And so being a vegan by itself or exercising may not be sufficient to address that. And important then to think about what might be leading to that high LDL. Is this a genetic abnormality? Are there other risk factors that might be at play? And discussing with your physician how to then screen for cardiovascular disease and plaque formation, knowing that LDL is so high.
All right, we'll get to one last question, Dr. Almeida. Mark is asking, if statins produce joint and body pains, is it better to be on a weaker statin than none at all?
Mark, thanks for that question. So this is one I get all the time in the office. The statins, in my opinion, have a bad reputation, right? There's a lot of misconceptions about them, and more often than not, people have heard from friends or family or neighbors that these statins have caused considerable side effects, and therefore they've had to stop. A lot of times, however, it's these medications are not the culprit and not the cause for these. They certainly do have side effects with muscle breakdown and muscle pain, but that tends to be rather unusual. So most of the time, they don't cause these symptoms. So what I do before I take someone off these medications, because they're so important and such a critical tool for fighting heart disease, I really want to challenge someone to say, is this in fact the cause of your symptoms? And if we need to, sometimes we might take a holiday period off of the medication for, say, a week or two to understand if those symptoms get better. If the symptoms don't get any better, then it's really hard to blame the statin. Well, we could go with a weaker statin, then you lose some of those benefits with plaque stabilization and anti-inflammatory benefits that you might get with a high intensity agent. And certainly, if you truly cannot tolerate it, there's ways to mitigate some of that slow symptoms with supplements that your doctor can discuss with you. But if you truly are intolerant, we don't want anyone to be miserable or affecting their quality of life on these medications. There are other tools in our arsenal that are non-statin medications, typically injectables, to help lower that risk and lower LDL as well.
Very good. Well, thank you so much, Dr. Almeida, for all your insight and answers today. Lots of important information that you were able to break down so we could all clearly understand. Thank you to our audience for tuning in today. We had some great comments. If you want to know more about TGH's Cardiometabolic Disease program, make sure to visit the web address that's on your screen right now, or you can scan that QR code to take you right there. You can also email us at the address on your screen or discuss a referral with your primary care provider. We want to thank everybody who joined us live today and submitted your fantastic questions. We look forward to seeing you on the next Ask an Expert series. We have two in March, one on endometriosis on the 19th and another on women's heart health and spontaneous coronary artery dissection, or SCAD, on the 25th. We hope that you'll join us then. Have a great rest of your day.